Thank you. Can you hear me? Is this on? Okay. Good afternoon, everyone. I'm a late addition to the panel due to some folks getting stranded. So just do a brief introduction and then I'll pass along to the other panelists. But I'm a public health veterinarian at Iowa State University. Currently serve as our university's inaugural public health coordinator. And that's a role that directly came out of the COVID-19 pandemic. So I have a bachelor's in zoology and a DVM from Iowa State University and an MPH from the University of Minnesota. I did do some companion animal private practice, but have spent most of my career in public health in the area of infectious disease. I served as an epidemiologist at the Iowa Department of Public Health for several years, worked on food and feed emergencies and some outbreak management and emergency preparedness and response, and then came to Iowa State in 2015. I have had a few roles at Iowa State. I initially served at the Center for Food Security and Public Health for several years. We do a lot of educational development and outreach on zoonotic diseases, biosecurity, foreign animal disease preparedness, especially having to do with food animals and protecting our food supply. I specifically worked on our National Veterinary Accreditation Program for anyone who might be familiar with that. And then also served a time as the Associate Director at an Antimicrobial Resistance Institute that is housed at Iowa State. And then I had just taken on a new role back at CFSPH when COVID hit and was asked to come over to main campus and serve as our acting COVID-19 public health coordinator. We in our county, our Iowa State population makes up about 2/3 of the population of our county. And our health department consists of about 2 people. 2 are part-time, 1 is full-time, so equivalent to 2 FTEs. They were not resourced whatsoever to handle the 30,000 students and 10,000 plus employees that we have at Iowa State. So we set up our own public health infrastructure, did our own contact tracing and case investigation, administered vaccines, all of that in very close collaboration with our local and state public health partners. That role was supposed to be for a semester. It went on for about 2 years. And eventually the university recognized that they would like to have a public health professional full-time. And so I moved into that role a little over a year ago. So I still work a lot on infectious disease. Mpox, or formerly known as monkeypox, is something our campus has worked with this past year. And then because of the global nature of our campus, we have a campus in Uganda, and so I'm responsible for doing disease surveillance all over the world just to monitor for issues we might be impacted by. So an infectious disease component, I do work closely with our emergency management team. Right now we're working to revise our pandemic preparedness plan based on lessons learned from COVID-19, so I'm leading the revision of that, and then also have a health promotion piece to my role now as well. So I do some mental health and suicide prevention training. I have a poster over in the poster presentation room. Also, we just conducted a community health needs assessment of our student body in the fall with some focus groups. So we pulled some qualitative and quantitative data to try to look at breaking that down by identity groups. And we did an environmental scan as well and compared to some best practices frameworks to look at who was utilizing our health and wellness services on campus, our student health center, rec services, mental health services, trying to look at if students were able to access that, if certain groups of students weren't able to access that, and also trying to assess where we had some gaps and maybe need to implement some new services. And so that's what the poster outlines, that process. We'll repeat that every 5 years, but helped with the data management and coordinating of that project as well. So it's an evolving field, and certainly the pandemic played a big role in where we've landed with our work at Iowa State. So happy to be here. Thank you. Who's next? Okay.
Oh. I have my own. Perfect. Hi, everyone. I'm Taylor Van Doren. I am, speaking for the second time today. Yeah, this thing is on. Okay. Just to get to know me a little bit, I'm currently a postdoctoral fellow at the Sitka Sound Science Center, where I'm working on a NSF Rapid grant to study risk perception and resilience in Southeast Alaska. But I'm actually a 1918 flu researcher originally, and I have bachelor's degrees in anthropology and chemistry, master's degrees in anthropology, and a PhD in anthropology. So I'm really, truly an anthropologist. I went to the University of Missouri for my master's and PhD, and I currently still live there, but work in Sitka. And, you know, I focused a lot on the 1918 flu originally and have a lot of training in historical demography and epidemiology, but I also got really into learning about how to study pandemics through archives as well. So I do a lot of mixed methods with vital records, census data, and just the historical record. And as an anthropologist, we're holistically trained to think about not just human biology, but also how humans experience the environment and how we behave. And through an anthropological lens, studying pandemics is actually really unique and is something that hasn't been taken up that often. And this is something that my colleagues and I are really trying to change, because pandemics are anthropogenic events, and we like to think of them as, you know, we experience them through our, historical population health. We experience them through our environments. We experience them through our behaviors. And so you really can't divorce the human experience from infectious diseases. And so that's the perspective that I'm coming from when I study pandemics. So I have some 1918 flu research under my belt. I have some COVID research under my belt. But also one of the things that I really like to emphasize is that the definition of pandemic can be a little bit iffy. So we actually have multiple pandemics going on at any given time. And so, truly thinking about what it means to experience a pandemic event through a human lens is the goal of a lot of my research. And so I think I want to end it there, and I'd love to hear what your questions are.
Hello, everyone. Dringwinzi, Shojri Elisa Alexander Oji, Vantakwichin Ifli Ga Tanan Guchi. So, my name is Elisa Alexander. I'm a family doctor, and I'm a member of the Vantakwichin First Nation, which is located in the Yukon Territory. And I am married to Edward Alexander, who's from Fort Yukon, which is why I live in Alaska. And I like to say that he's from downriver, which doesn't happen very often for Fort Yukoners. So I am actually a baby anthropologist. I did my first degree in anthropology, and then I went on to be an MD. I studied in Ontario, and then I went to do my residency training in a program in Victoria called the Aboriginal Family Medicine Program. And so we work specifically in Indigenous communities and train physicians to work in resource-stretched areas and isolated communities. So I always wanted to go back and work in the Yukon, and then I met Ed again and came over here, and I spent 5 years working in Fort Yukon. And I have spent the last 5-6 years working in Fairbanks at Tanana Chiefs Conference. And I came into this role right at the beginning of the pandemic. And so I have a couple slides that I'll share with you about Tanana Chiefs Conference for those of you that are not from here. So we're organized as Dana Nana Hanesh, which translates to Our Land Speaks. We have 42 tribal tribes that are members of our organization, and they're our governing body. So we deliver services that respect traditional values of the tribes and communities, and including healthcare. We serve roughly 19,500 people in interior Alaska, 16,500 Alaska Native American Indian people, and about 3,000 we call them Indian Health Service beneficiaries, and we also have a small population of veterans that we serve. So this is our vision statement, and I wanted to share this with you because I think it really incorporates the One Health philosophy. So we vision healthy people across generations, and our mission at Tanana Chiefs Conference is TCC Health Services, in partnership with those we serve, promotes and enhances spiritual, physical, mental, and emotional wellness through education, prevention, and the delivery of quality services. In, I think it was 2019, TCC adopted a guiding principle for how we deliver care in our communities and to our membership, and it's called Sewitson. And this is based on Chief Peter John from Minto, and there's a book, kind of biography written by him. And so essentially what it is accessible, trusted, world-class services provided with unconditional love, compassion, dignity, and respect. Hear me, okay? So just for those of you that aren't from Alaska, I wanted to give an idea of the region that we serve. So in Tanana Chiefs Conference, this is the region that we're responsible for, and what our membership is. And you can see in the little green box, the lower 48 there, the red is how big Alaska is, and then the blue is the region that Tanana Chiefs Conference works for. And for those of you, again, that are not from Alaska, the Alaska Tribal Health System has 25 different tribal health organizations that serve the Indigenous people in Alaska. So we are one of those co-signers. And you can also see the network. I wanted to include this slide particularly for this talk because you can see our referral patterns and flight patterns in and out of our villages and how complex the situation is, especially when we have hospitals that are concentrated in very specific areas. And I think that might be the last slide. Yeah, so I'm happy to answer any questions. I think when the pandemic hit, for us, this was a very concerning and complex situation that we had to address with our villages being mostly accessible by air only, and small and very close-knit communities. And so we worked very closely with the state and the federal government in quickly responding to how we could protect our community members. So happy to answer any questions.
Thank you very much to all of our panelists. It's fascinating. I'll start off with a question to get things going, and please, everybody jump in. But as a general question to our three panelists, what do you see as the greatest impact of the COVID-19 pandemic, and how would you like to see things change to be better prepared for future pandemics? Whoever feels inspired to lead off with that.
Oh, it doesn't matter.
This is kind of the question, I think. Yeah. The greatest, from my perspective, the greatest impact is the recognition that everything was impacted, how complex it really was. It's not just about, the novel SARS coronavirus 2. It's about how that virus has changed everything about the way that we think about pandemics, the way we interact with one another. It's changed our politics. It's changed our education. It's changed everything. And, we can think about it in terms of population health, of course, about, the proximate measures, like how many people got it, how it was transmitted, and how many people, unfortunately, didn't make it out of this pandemic. But it impacted so much more than that too. And that's what's really stuck with me as somebody who really tries to understand social and historical determinants of inequality and how people experience infectious diseases and how layered all of these things are, and how, I will never know what all the impacts have been. But I that's what stuck with me the most. And in terms of preparedness to do better, is that the second part of the question? In terms of preparedness, I think that's just what, I think that having that recognition that, it's really, I think, okay, I'm gonna restart my answer to that question, because I think the really important part is the fact that we're focusing on preparedness and not just on prevention, because I don't think another pandemic can be prevented. I think there's too many things happening all at once. A word I haven't heard today mentioned in any of the other talks is spillover, and how there's spillover happening from, non-human animals to humans basically every day, and how pandemics are going to happen and continue happening, right? And so I think what's important is the focus on preparedness. I think what's really important is, as a 1918 flu scholar, is that kind of became the forgotten pandemic of the 20th century until about 4 years ago, 3 or 4 years ago. And what we can't do is forget what we all experienced. I think there was a lot of incentive to forget what happened in the 1910s with the First World War and the 1918 flu altogether. And people were just desperate to forget about it. But we can't do that anymore, and we can't be complacent. So I think in terms of preparedness is that recognition that we cannot be complacent anymore about what we experienced these last few years.
Wholeheartedly agree with everything that Taylor said. I think some of the biggest impacts, as she mentioned, were health inequities and just how that was so systemically highlighted throughout the pandemic in so many areas. And as she said, that interconnectedness. So being in Iowa, for example, we are the #1 hog producing state in the U.S. And so we were one of the states that was heavily impacted when the packing plants were shut down. We had a lot of hogs being euthanized in our state, perfectly healthy animals that should have gone into the food supply, lots of mental health issues that came out of that from the folks who were having to euthanize, depopulate those animals, and were raising those animals, relied on them for their livelihood. And so that domino effect, in the health inequities we were seeing with people not being able to access what they needed, not getting the information that they needed, and how siloed we were in so many things. And I think anyone working in the field kind of saw these red flags happening over the years, but then this really just laid it out on display for everyone to see, and then went on for so long, which I think was the piece that really we truly weren't prepared for. And it just highlighted how we didn't respect and recognize the interconnectedness of our planet and why that's so important, right? And it will continue the spillovers, and it's not an if, it's a when, and we have to learn to respect and use that indigenous knowledge, go back to those principles and respect our planet and the fact that we are all connected, and how do we do it better? So one thing I would say for moving forward, funding is a huge thing. So we have seen over and over again in history where we have a public health issue, funding gets dumped into it, and then as soon as it goes away, or we are able to kind of forget about it, the funding dries up until the next thing happens. I hope one thing that comes out of COVID is the recognition that that is not a sustainable way to move forward with public health. The systemic changes that need to take place to address the health inequities, systemic racism, all of those pieces, these are big challenges, but we have to take steps to overcoming them. I also think one thing that I particularly experienced was just as a public health professional, we're used to kind of being in the background doing that social or that science work. All of a sudden that became very political. Science is not trusted the way that it was. There's, just the communication piece is going to be so huge moving forward. So we have to break out of our silos. We have to find ways to communicate with people in a way that isn't shaming people for their beliefs, but how do we get the resources and the knowledge and the communication out to folks in a way that resonates with them from a trusted source and all those different groups, and that is going to take far more than just science to accomplish that. So I think that's a heavy lift. It's not going to happen overnight, but certainly we have to do better next time, and we've seen what happens when we're not prepared and when we don't respect and recognize how interconnected our planet is, and what happens when we don't work together. So one thing I saw at Iowa State, in academia, we often get so siloed, and really it forced us to break out of those silos. And so just even within our little campus community, we pulled people onto our public health team from the sociology department, from the economics department, from the statistics department. So it was this really unique thing to be part of a university where we had all of these people with lots of expertise. None of us knew each other, but here we were being forced, not forced, I don't want to say that, but kind of having to work together to solve this huge problem that, we didn't have a lot of information about at first. And it really provided this kind of an opportunity to see what it's like to work from that more One Health perspective and what happens when we all come to the table together instead of me trying to prove how much I know and you don't. We really came with like, okay, here's what I bring. This is your skill set. How do we work together to make this happen and keep people safe? So, yeah, that's a huge answer, but I think the communication piece is going to be huge. It's always been huge, but it really got highlighted during COVID that we need to find a way to communicate with people in a trusted way, and that's going to take a lot of momentum moving forward from a whole lot of people. So One Health at its best.
So I completely agree with everything Kristen and Taylor said. I think from the perspective I was sitting in and what I've seen happen, so I was fairly new to my role when I was literally in my role, I think, for a month before the pandemic hit. And as an organization, Tanana Chiefs Conference is used to responding to emergencies in our region. So we respond to floods in springtime. We respond to wildfires in the summer. We have a very robust incident command system. So it was really easy for us to stand that up. And I think one of the things that it highlighted for me is, and Taylor kind of touched on this earlier in her presentation, but one of the biggest protective factors for our communities and that allowed us to protect our communities was our relationship in our communities, our relationships within the communities and our relationship to our communities. Right away, we had a robust communication plan with all of our villages. We stood up actually initially daily debriefings with 42 tribes and then anyone else that was welcome to come in. So we had public health nursing. We worked really closely with Dr. Ann Zink, who couldn't make it today because she was weathered in. We had just these huge platforms for communication to get information out to our villages. And I think the relationships that we had with our community members, our partners in town, and at the state and federal level were really key. I was talking to the former chief chairman who was the lead of our organization at the time, and he was reflecting back on the pandemic, and he was actually a part of President Biden's COVID-19 task force. So what really stood out for him, and I agree, is that a lot of the people that we had working with us at the table were open to communication and relationship. And so without having Dr. Ann Zink in there and how proactive she was at being available to really every community and every organization all of the time and sharing as much information as she did, without that relationship with us, I think it would have been really, really difficult for us to navigate the pandemic for our communities. And so I think relationship and communication are critical moving forward and really critical protective factors for our community members. I can't remember who it was, but there was an audience member who talked about how do we get people to trust government officials and the information that's coming out, and relationships are just critically important to that. So.
Anyone care to ask a question or comment on those responses? Yes.
Yeah, so I'd like to just expand upon briefly something I believe all three of you brought up. I find it very interesting that a lot of public health issues, whether it's due to messaging or mistrust, kind of turn into political issues and they don't stay as public health issues. So I guess in your guys' best opinions, is it more about the communications or the messaging to prevent that from happening? And I guess what are some steps we can take to ensure more trust in public health officials and government officials so that the conversation doesn't, devolve into something that's not as productive?
So one of the things, and I use this in my approach just as a family doctor as well, I think it's really important to be honest with people. So that was one of the things that we did at the beginning of the pandemic when we were trying to explain what was going on, being honest about what you know and what you don't know, and saying it's okay to say we don't know at this time and things are going to change. And because we started that messaging early with our community members, like this is the piece that we know right now, these are all the pieces that we don't know yet, and there's probably a bunch of stuff that we don't know to ask yet. But because we started that messaging early, when messages changed and the guidance changed, it allowed people to be more flexible and adaptable to that. So I think being honest and transparent is really, really important for gaining people's trust. And like I said, I do that as a family doctor when I work with patients as well. So.
Yeah, I think I would wholeheartedly agree. I think being very upfront with folks about being transparent and what you do know, what you don't know, particularly with an emerging disease like COVID. Also helping them to see, kind of laying it out like we expect things to change, so that when we see, one thing that I still get a lot of questions about is the variants that are coming and how those are evolving over time. That's expected to a certain extent, right? And when people know that, it brings some reassurance. And, again, we don't know everything about those new variants, but that is what viruses do. And so when you can help to explain to folks that, here's what we might see. Another question that we often got, it was often very critical, is, as the pandemic shifted and we kind of moved away from the case investigation and contact tracing, those are public health tools. And so kind of helping people to understand we have a toolbox, and these are tools we'll use at this point in an outbreak or a pandemic, and those tools may not be as useful later. Instead, we're going to move to these vaccines, and you're building up natural immunity in the community, and helping people to understand that you're not just quitting, but there's thought process behind why we do those things, so that it does help to build some trust. So if you can help people to understand the why behind what you're doing, and then I would go back to what you said earlier with the relationships. To me, that's if people are hearing information, I'm glad you used that word, because I think you're right. It is the communication, but it's about it coming, to me anyway, from a trusted source. So what are the relationships people have with the people that they're getting the information from? Because to me, that's where you start to build that trust. People see that person as caring about them and not just filling them full of information, and then tailoring the message to that community that you're talking to, right? So some folks want to see data. A lot of people don't care about data. So being aware of what's the information people want and need, and then how do we get that to them in a way that they can trust what's being said.
I have to be very open about the fact that I don't know that much about public health communication and public health messaging. I am just as concerned about this as the next person, because, I've been also living through these 3 years, and it's difficult to have conversations when they devolve into something that you can't handle anymore from a scientific perspective. I found that my personal best weapon is objectivity and trying to discuss the facts, right? Like I know people don't care about data, but data is an incredible source, and it's, you can use it as your, I like to use it as kind of not a weapon, but like as something I can always go back to and say, these are the data right now, this is what's happening. Just from a personal, standpoint, I personally have a lot of family who, haven't been able to look at the pandemic very objectively, are very quick to going to those political arguments. And something that really stands out to me that happened right when the vaccine started coming out was my dad came to me and said, okay, I'm very worried about these vaccines for XYZ reason. A lot of vaccine propaganda was behind his fear. And he said, can you please explain to me how the vaccine works? And luckily, I knew enough microbiology to explain how the vaccine works. And I was able to convince him to get it, even though everything he was seeing online and from other family members was telling him not to get it. So I try to always come from a place of objectivity as best as I can, and data. And of course, the data are going to change. The story is going to change. If people don't understand how the process of science works, then they don't understand why the protocols were being changed so rapidly in 2020, or where these variants are coming from. And it's I agree. I'm not sure I have an answer to this question, but I'm gonna keep going back to using and having confidence in my own knowledge as a scientist, and being able to point to things that we're pretty sure we know about. Yeah.
Can I add just something quickly? Taylor, you reminded me too. I really had to shift. So as a public health professional, as someone who hadn't really been in a political role before, and then all of a sudden I was, and doing media requests, that got very heated at times and things like that. Having to learn to approach things with curiosity and empathy instead of, like, well, duh, the data say this, why don't you believe me, right? That doesn't work. So just really having to shift my mindset to, like, really trying to understand, where is this person coming from? And like you said, where are they getting their information from? What are they basing that thought process on? And then sharing some objective facts in a way that you can help them come to that thought process, but really approaching it with curiosity. And that can be very challenging to do when you feel like you're on the defense. But when you can do that and try to come to an understanding, it helped me learn a lot too. So.
Thanks. Yeah, you can hear me. Solveig Jorde, Public Health Norway. So I'm interested in what you think about the lessons learned, and then in terms of the societal restrictions imposed. I mean, we know there's going to be more pandemics. So would you still advise closing down the schools? Would you still, impose so hard restrictions? And, I think that would be interesting. And also, I think, when you say that, I think it's very, very hard in terms of communication. I was part of the pandemic response at the Norwegian Public Health Institute in terms of dealing with what type of restriction we should impose, and I found it incredible difficult, actually. But I think also it was very difficult to communicate risk in a proper way, and in terms of the vaccines, because it was very polarized. It was either you were pro-vaccination or you were against. And to be honest, I was thinking that it was very difficult to be honest and say that, look here, there's actually some harms from the vaccines as well. And so I think it was difficult to actually take that discussion, because then you would, and I didn't take that sort of because of how polarized the discussion was. It was some ways too difficult. But I made a choice as a mother for 3 children that didn't necessarily follow the recommendation that came nationally, because I think and we know the risks were different for young people compared to if you're 60. And there were also, we saw that there came, different kinds of problems for youth, especially young men. And I don't think it was not easy to discuss that, because if you took that in public, you would be taken to be against vaccination, and that would be I would definitely not fall into that. part of the discussion. So I think it's really demanding to have a really open and unbiased discussion about the pros and cons of vaccination. As one example, but I think I'm especially interested in what you think about the school closures.
So the school closures, among our medical staff, that was a real point of contention. The pediatricians did not want to close the schools, and for a lot of our smaller communities and villages, they were able to navigate keeping their schools open because it's so important for the children in terms of socialization, but also access to regular meals and social support and stuff like that. So a lot of our smaller communities were able to navigate that and stay open during that time with careful testing and stuff like that. And in terms of, would we recommend closing down as much as we did? One of the things I think that we're really seeing across healthcare now, and this was touched on earlier in one of the presentations, is the lack of access to services during that time, particularly in health, and how that's impacting what people are dealing with now. And so I think we developed some tools during this time to ensure that there is continued access to healthcare, but I think that there's more work that needs to be done there to make sure that people have the access they need and are not fearful of going for healthcare when they need it, because we are seeing delayed cancer diagnoses and untreated medical conditions now that have gone on for a long time. So I think that there's a lot more work to be done in that area. But I do think the tools that we developed along using remote telemedicine and increasing access that way have been helpful. I think there's a lot of room to grow that as well so that it can be more effective for people.
Yeah, the topic of school closures is a really interesting one, because I agree that closing schools probably wasn't in the best interest of most people involved, or really anyone, in terms of like tampering the spread of the virus. It was probably a good strategy, but at what cost, right? Because K through 12 kids are not at super high risk of adverse COVID, consequences. They're not a super high risk group, but they transmit everything. And schools are hotspots for transmission. So in terms of trying to reduce the spread, that might have helped. But again, at what cost? At what cost to the children who depend on breakfast and lunch at school, to the cost of disproportionately women and mothers who needed to stay home and put their jobs on hold and go through the remote schooling, and in terms of children's development and actually being in those social situations, because school is not just about learning information, it's about learning how to interact with your peers and how to be an adult eventually. So from an epidemiological perspective, it was a strategy, but from an outcomes perspective, I definitely would not recommend that again. I'm not a person who has power to make recommendations. I don't work in public health, but I think that there's a cost benefit, I guess, analysis that can be done that would lean more towards, what do we do now to make sure that, a future pandemic doesn't get totally out of control. Regular testing with, regular, masking, if I think I think masking works. I think people are confused about that right now. People have always been confused about masking, at least where I live. But with good, practical, and sustainable public health measures, you can continue to go to school during a pandemic. So I wouldn't start anymore with closing K through 12 schools in the U.S. That's my personal perspective of that.
Yeah, I think one unique thing, we're a public institution. There's 3 public universities in the state of Iowa, and so we're all under the jurisdiction of our Board of Regents. And so I can say as a public health professional, that often put us in a tight spot. Iowa was a state where we did not put a lot of mandates into place. Masking was thought to be more of a personal choice. There were, as in most states, it got very political, but we tended to be a state where some of those practices that were put into place in other states, we didn't do a lot of that. And so even in moments where as a public health professional, I maybe thought it was in our best interest to take our classes online based on our case counts and other things we were monitoring. We were told at times that that was no longer an option. We did go online for some time. And then in our campus is not really a remote campus, so the majority of our students live on campus or in apartments near campus. So we're really an institution where our students are coming and going from campus in person. That's something we pride ourselves in our educational delivery. And so our congregate living settings were another big challenge. So, even if we had taken our students online for courses, the majority of them still would have been living in our dormitories. And so that presents its own challenge from an infectious disease standpoint. So that was something we were really struck with. And then we did go online for a time. And I think now, as with our K-12 students, we're really starting to see the more long-term implications of, the impacts that had on mental health, on our students' ability to kind of do that time management piece and balance courses and what other activities do I want to be involved in, because that stopped for a period of time. And for some of those students, they're just now kind of experiencing that in what we would term a more, new normal way, whatever that may be at this point. But so I think in Iowa was a state where a lot of our schools also stayed in session. So my son's school never went online, for example. And so as a parent, I didn't experience a lot of the things that some of my colleagues did, having to work with their children at home. So they're just, to me, the word I think of, I guess, when I look back on that is that balance piece. So, and again, we didn't know a lot of things about COVID at first. And so with the information we had at the time, was that the best decision? Looking back on it, maybe not. But with the information we had at the time, how did we know it wouldn't be later? And so it's kind of that we do learn new things as the pandemic goes on. Each disease is a little bit different, spreads in a different way. New populations of folks can be impacted by different pathogens more than others. And so the next pandemic may look totally different. And again, it's going to be, anytime there's an emerging disease, we don't have all the information up front. And so I think it's just that having to take a step back. What do we know? What don't we know? We learned a lot from COVID and those long-term impacts of what happens when we ask people to isolate and you lose that social connectedness and our students are not in schools. That has a big impact on folks too. So I think we've all learned a lot of things from those experiences, and in the future we'll be able to use that information to hopefully better inform what we do based on the information we have at that time for whatever that next pathogen is. But it is challenging, and it has to evolve, I think, as you do learn more and a pandemic progresses, not being afraid to take a step back and say, this isn't really serving us very well anymore with the information we have now, and we need to adjust to try to strike that balance as best you can. So.
This is a fascinating discussion, and as I reflect on this, talking about like unintended consequences of school closures as an example, but a lot of what we did and what was suggested or mandated in many cases was presented as a way to protect others that are more vulnerable than an individual might be. So masking was initially presented as, and perhaps it truly is, a way to protect somebody else from your own, your own virus load, rather than a self-serving act, But what fascinates me about this discussion is, in a public health context, how do we evaluate like the development of a child, social development of a child, against the potential severe illness of those that that child might live with or might associate with. Like, what is an acceptable how do we draw that balance, and is that an area of research? I guess this would be primarily a question for Dr. Clark. Is that an area of research, and is there thought being put to that?
Yeah, I'm not personally involved in any research like that, but I think that is such a tough question to answer, right? And depending on who you are in society, if you have children, if you don't have children, if you live with an older adult, if you have immunocompromised folks in your family or in your household, you will have different opinions about that. And certainly, I think one thing we kept coming back to, right or wrong, is everyone has their own, each of us individually, we have our own comfort level with risk and what we're comfortable with and what we're not comfortable with. And that varies so much from individual to individual, just surely based on your health status for one factor, but a whole lot of other things. And so, yeah, gosh, I don't know that I have a great answer for that. It is so challenging, right? Because is the health of the older immunocompromised adult that lives in your household more important than your students' development in school? I don't know that anyone has a great answer to that question. And so I think, and another thing, we did the same thing. So we had Iowa State, our mascot is the Cyclones. And so one of the things we did was a Cyclones Cares campaign. And we really had these kind of 4 main components to wash your hands, wear a mask for a time when we were able to require that, which was not for a very long time on our campus. Kind of those principles, stay home when you're sick. And it was really meant to build this sense of community on our campus about you're doing this to protect other people. And then I mentioned in our political, environment in Iowa, personal choice is a very strong sentiment there. And so at the end of the day, for some of those folks, that argument does not work. The do this to protect your neighbor, they're like, no, this is my choice and I don't want you to tell me what to do. So again, it's kind of finding the balance. Do we ever find it perfectly? I would say absolutely not. There's always going to be unintended consequences. There's always going to be, because of the social inequalities that are in place in our societies globally, there will always be people who are more heavily impacted than others. Does that make that okay? No, it doesn't. But I think that's why we have to keep trying to do better, keep learning, keep working together. It just makes it all the more important that we all start connecting in this one health, planetary health mindset, because that's the only way that we can do better the next time around. And we still won't do it perfectly, but hopefully we can keep taking steps in the right direction to find that balance, whatever it may be for the next thing that impacts us. So. One unique thing I wanted to mention, we had a pretty significant natural disaster happen in our area right in the middle of the beginning of the pandemic. And so then we also were dealing with that in addition to the challenges of the pandemic. And it really just brought to light, then there were a whole new host of, we had people that weren't able to go back into their homes because they had been destroyed by this storm that we had. And students who were heavily impacted, that we went online and all of a sudden they weren't allowed to stay on campus in their dorm, but they didn't have a home they could go back home to because it had been destroyed in the storm. And so, we had students that didn't have internet access because of that, and we were asking them to take classes online. And so, Mother Nature is in charge at the end of the day. And so we just have to continually work together to try to do better and find that balance, and it changes by the day and very quickly. So not a very hopeful answer, but that would be my response.
Just listening to you talk kind of reminded me of one of the things in our communities, and I think Taylor's research kind of touches on this too in Southeast, is for our communities and our villages, the history of pandemics that have hit our community members is living memory. And so we have people alive that have survived TB pandemics and, remember when the flu hit and remember our villages being completely decimated by this. And so asking people to wear a mask for other people was really easy. and asking people to wash their hands and do all the protective things that we asked was really easy because those stories have been passed down or they're still alive in those communities. And you walk through our communities and you see the cemeteries with the little tiny graveyards of like 2-year-olds that died from the flu. And so it's really easy to keep other people in your mind. And so we didn't struggle with that like requirement for masking and stuff like that in our communities as much as other people. And similarly with our vaccination rates, we have extremely high vaccination rates compared to the general public because of it being in living memory, which is a protective thing and also really tragic in a lot of other ways, right? So.
I just wanted to follow up on that, and I'm wondering if all the politicization that happened. I just wanted to follow up on that, and with all the politicalization that happened after COVID, do you feel like that's still in place? That cultural perspective is intact, or has that eroded?
I would say that in the region that I work in, there is a small percentage of people that are, anti-vaxxers and anti-mask and that sort of stuff. But I would say, more often, you're going to find people that are willing to continue to do the things that they need to. Because in our communities, like one of the panelists mentioned this morning, you know everybody, and otherwise you're related to everybody. Like the village that I'm from, I'm related to 90% of the village. So it's not a stretch for us to be worried about other people. And it's harder, like when you come from a community of 100,000 people, to always be worried about your neighbor or, so.
Yeah, just building off that, I'm really grateful for your answer, and I'm glad you brought that up. There's so much. There's such a sense of individualism in a lot of, at least everywhere I've ever lived. It's really all about me, and my well-being, and it's hard to behave like you're in a community when that's the dominant perspective. And I live in a town of 140,000 people. I don't know everyone. I don't know who lives next to me. I know the demographics of the people who live around me because they're all college kids and they are of a certain age and they do certain things. But you still have community within that space. So think about, the couple dozen people that you interact with, right? There's no excuse not to develop a community still and put their needs, if not above your own, but at your own level. I just don't think that there's an excuse not to think about other people that you come into contact with on the daily, because we're all in this together in a big sense. And I don't want to be like a bleeding heart up here, but honestly, it's, learning about working in this job and learning about the Alaska Native people who were grateful. I'm very grateful that they, did these interviews and we could learn from them. They've really contributed so much knowledge to, to science, because really for them it was all about what, basically like, tell me what I need to do so I can get back in a room face to face with these people, and I'll do it. Tell me what we have to do. And I think in a lot of cases, where I'm from, it was very independently mindset, right? Masking is a choice, et cetera, et cetera. But I think it's also important to realize that that's a generalization, and there are going to be people in your community who are like-minded, like you, and there are people out there who are trying to elevate the needs of the community before their own, even in places where individualism is dominating. So, yeah.
segment of population that's missing now. There's like over 250,000 students that have just not come back to school, right? And so beyond, we accounted for the ones that are going to homeschool and then have come back to public school, and then there's this whole missing segment of students, right? And so we've seen closures in schools here at Fairbanks. We've seen closures in Anchorage, a bunch of schools because of funding being derived on student counts, right? I guess the question is there something similar occurring for the health profession itself, right? And so, we talked about the impacts to veterinary folks when there was a big die-off of hogs in Iowa during COVID-19. And so there was increased stress on those peoples and families and everything like that. There was increased stress on families in the COVID-19 pandemic for medical staff, right? We saw a huge retirement for educators during that time period. So now there's a hiring crisis for teachers and so forth in education too, which is, ironically, swollen class sizes and increased, I'm sure, disease risk and stuff in all those places. But is there something similar going on in health, or are people not becoming vets or not becoming doctors, or is there impacts on the health system itself to vets and to medical schools and that kind of thing?
So I would say absolutely. And full disclosure, that's my husband. So I would say absolutely. In the medical field, like you mentioned, early retirement, people leaving to try to balance work and life and family. I think work or life outside of work became more important for people because you saw, just it kind of elevated the things that are important for people in their lives. What we see happening in Alaska right now, and I'm not sure how many of you are from here, but the hospital systems are full, and they're not full from COVID anymore. They're full because we don't have enough staff to staff the beds. And what that means is our smaller communities and our smaller hospitals, when they fill up, they have nowhere to send patients. So they have to still call each other and say, will you take this person that's critically ill? And sometimes that person that's critically ill has to stay in the village with limited healthcare resources during that time. And so there's a real strain on access to medical resources now. And it kind of is amplified by this history, the last 3 years of people having limited access and then being sicker, having diagnoses that require more care, and they're not able to access those services. So there's a huge strain on the healthcare system from my perspective, and how do we fix that to make sure that people can continue to have this critical access to care? I'm not sure what the answer is right now, but I do think like we're going to have to look at more alternative staffing models and more flexibility in work arrangements and all sorts of things, especially to accommodate for the increased stress that people are having by being short-staffed and having to look after larger workloads.
Yeah, I can say we are 100% seeing the same thing on the veterinary side. So in public health in general, they talked for a while after the pandemic about the Fauci effect, that it kind of stimulated interest in folks going into public health fields. I think while we did see that, as you said, folks have prioritized things a little bit differently. That's one of the things we really seen shift over the past couple of years. They want more flexibility in their jobs. We saw that could be done, and so now that's an expectation that wasn't there before. So in the veterinary field, we see that not only with veterinarians but also with our veterinary technicians. So very similar challenges. Folks can't get in for appointments. Folks who are working are very overstressed, overworked, working long hours. Our students who are coming out of veterinary colleges are having different life demands or different demands when they're being hired. They're demanding, I will not work on call. I am not willing to do this like people may have done differently. Even when I was coming out of school, I won't tell you how long ago that was, but long enough ago that it was different. we're really seeing a shift, and I serve on our American Veterinary Medical Association House of Delegates, and I can tell you at our last 3, so we meet twice a year together as a group, and the biggest topic of conversation at our last 3 meetings we've had has been staffing. Again, like you said, looking at alternative staffing models. How do we meet the demand that's out there? And probably really what's impacted is our rural areas, because we're seeing that veterinarians aren't able to make a living there. And so loan forgiveness programs are something, they have those in the human health profession as well, that are becoming something that's really important, because with the amount of debt we come out of school with, they're not able to make a living. And so particularly in our rural areas where we have our food animals, people can't find veterinary care. It's very, I grew up in an area like that. My parents have to drive 2 hours to find a veterinarian to look at their large animals. And so, and when we don't protect animal health, we're not protecting human health either, right? So animals serve as sentinels. We have zoonotic diseases that pass from animals to humans. You know, even things like animal abuse can be a red flag for domestic abuse, child abuse that's in the home. Veterinarians can be folks who are the first to see that. And so when we have all of those things, all those needs not being met, we're going to see the health implications of that widespread. And so the veterinary profession is very aware of it. We are trying to be very creative about how we're addressing it, but it's going to be a problem that goes on for quite a while. And I saw similar things now that kind of that Fauci effect has subsided, and people have seen how politicized the public health field has become, that some folks are shying away from going into it because of that as well.
I just want to add one thing to those excellent answers, and that is that it's just the reminder that we've all been through like a lot of trauma these last few years. Pandemics are traumatizing, and some people have experienced that more than others, but I can't stop thinking about how doctors are often co-survivors of traumatic events, and how my husband, his first year of residency was 2020 to 2021 in internal medicine, and you know, there's just a lot of doctors who can't take the fact that so many people died who were not supposed to die, and how that might not be something that you want to endure in your profession. And so, you know, I think there's a certain level of, you know, self-protection also that has to happen, and that you really assess, is this the job for me? Is this something that I can handle as a person in my spirit? And you know, there are a lot of doctors who I personally know who have decided that it isn't. And so yeah, I mean, that's an assessment that you have to make on an individual level, but yeah, that's all I wanted to add to that. In terms of other institutions, I mean, I'm in academia. One thing that I'm concerned about in the workforce is potentially what's going to happen to the representation of young women and mothers and other marginalized people in academia. There were some studies that came out that showed that productivity during the pandemic actually increased, but when you break it down by demographics, it was actually white middle-aged men who were producing a ton of research during the COVID pandemic. You know, personally, as a mother of a young child in academia, I don't see how I could have produced anything during the pandemic. I was, you know, young mothers and young women and women in general are going to get left behind. It charges interest over a long period of time. So that's just what I've observed. Yeah.
Hi. I just had a question about creating more equity in public health. I think the pandemic did a really good job of showing us how these systematic oppressions and racism and colonization have continued to affect public health. And it's not just access to a medical facility, say. There's distrust in the medical field, even if it hasn't been politicized, as well as other barriers that just compound for life and create, you know, this disparity in numbers where Indigenous folks and Black and other minority groups are being affected by pandemic-like or diseases at a greater rate. So what can we say COVID-19 has taught us about trying to close that gap and create equity going forward?
Yeah, thanks for that question. One thing that I've learned a lot in the last year, because we are doing community-based research, and the research that's been coming out of the Science Center always strives to be community-based, right? Starting with what do you want to know, what knowledge can you use, and what I have found most important coming out of the first year of my postdoc is learning that listening to what people know, like learning their knowledge, using what they know to integrate that into what we've taken for granted as, public health, mitigation and plans and things like that. Drawing upon community knowledge is essential, especially when you're working with Native groups, and it's a co-production of knowledge situation where they're going to tell you what is best for them. And a group of settlers, making these pandemic mitigation plans doesn't necessarily know what's best for them. The community knows what's best for them. And so an increase in diverse representation into what actually goes into these plans is going to be essential. I have colleagues who are, from a broader view, I have colleagues who are completely allergic to even talking about historical marginalization and colonization, and how health inequities that we observe today are products of hundreds and hundreds of years of marginalization. Some people just don't know how to conceptualize that and think about how that affects modern population health. I think that having, this was on the topic of the research that we've been doing, having Native people at the table to say, this is what we know, this is what is happening, is extremely powerful. And that knowledge, unfortunately, okay, I'm gonna say something, it's still gonna answer the question, but it's a little bit tangential. It's going to take a total reframing of how we value Indigenous knowledge compared to Western science, because Indigenous knowledge is valuable, it is essential, and Western science cannot explain everything, right? And the devaluing of Indigenous knowledge is going to be detrimental to pandemic, mitigation and preparedness plans. So I kind of want to leave it there and pass it on to.
So thanks for the question and thanks for the answer. So the health inequities that currently exist, I would say in our organization and my experience as an Indigenous physician, it's been something that I've seen for a long time. I appreciate that the pandemic has highlighted it and made it more of a public conversation, or something that's talked about more and recognized, and actually is transparent in data now, because in Alaska Natives had the highest rate of mortality associated with COVID-19. And that's due to a whole myriad of reasons. But moving forward, what does that look like? I think there's a couple of interesting things. The Joint Commission, which accredits hospital institutions across the country, and they've made it a part of their accreditation process now that you have a health equity policy and you work towards it. And so I think that's a really good thing. I think as healthcare professionals, we tend to not acknowledge the inequities that exist because we treat the person in front of us, and so we think that we treat everybody the same. But if you look at the data on a population scale, that's not what the case is. And so making it mandatory for hospital institutions and other healthcare institutions to have a dedicated approach to working on these inequities is, I think, a step in the right direction. From my perspective, working for a tribal health organization in Alaska, I don't think that we're perfect in the way that we approach it, but I do think giving Indigenous people, for speaking from an Indigenous perspective, giving Indigenous people control over how they deliver healthcare and listen to their community members is critically important. So I'll just give one example, and this isn't related to COVID-19 specifically, but in our population, we have a really high rate of colorectal cancer. And so we have a study that we did among our population looking at the rates of adenoma detection. And based on what we found there, we have mandated in our organization that we screen people every 5 years with a colonoscopy, which goes, and at younger ages. So we start at age 40, which compared to national guidelines, they don't reflect the healthcare need in our population. Without us being able to control the data and control the questions that are being asked and respond to the concerns of the community, that specific directive and intervention wouldn't come to light. So I think that's really important in the state of Alaska. They're starting to talk about compacting education as well in the tribes, and I think that's another thing we need to give control back to the instead of like having a paternalistic approach to how we deliver stuff to people, we need to have them at the table. Give control back.
Yeah, I don't have, you both answered that really well, so thank you for that. I don't have a whole lot to add. I think we talk a lot about nothing about us without us, so making sure people are at the table, that those marginalized voices are heard, and then also that we're actually listening, so, and willing to do the work. And I think sometimes in academia, we are required to meet certain DEI standards and things like that, but sometimes it's often seen as a more performative act, or we can check that box off and move on. But how do we make social justice and health equity the foundation of what we're doing? Not just a box to check off, but what we're doing really needs to be rooted in that and done through that lens. And I think, as you both have said, not coming in and telling people what they need, but actually listening to what the needs are. And they won't be the same across populations. We know that, right? So our LGBTQIA students don't have the same needs that our students of color do. And the other thing we have to recognize is the intersectionality of folks who may be LGBTQIA and a student of color. So that also compounds what they experience and feel in their lives. And so just having to take a really critical look at that and coming to grips with the work that we need to do, and then bringing people into the conversation and giving them the power back to make the changes that are necessary.
I'm just going to add one thing real quick. I kind of riffing off what you said about box checking, right? I think it's going to require a reframing of how we think about what DEI representation is, in the sense that it's not an invitation to join our table for X amount of time. It's an expectation that diversity, equity, and inclusion is the norm, not the exception.
Switching gears a little bit, I'm very curious to hear the different environmental implications each of you might have observed. It seems like you guys each kind of come from a pretty unique environment or jurisdiction, so I'd be curious to hear about the different environmental implications you guys noticed on both your local level, maybe a regional level, and also the global level of the pandemic.
So I'll try to answer that question a little bit. It's an interesting question. I'm not sure that I will have a complete answer to it, but just looking at how we delivered healthcare in our region during this time, initially, what some of the impacts have been from the pandemic is a decreased access to services from our villages that already had low access to services. So, for example, a lot of our communities are only accessible by plane, and one of our airlines stopped servicing a number of our communities during that time, and our flight numbers went down drastically because of the economic impact to those airlines. So what does that mean for our communities? That means decreased access to goods and freight and food, increased cost of food in the communities, decreased access to traveling out for medical appointments or things like that. Fuel consumption probably went down for that. But then when you look at how we responded as an organization to getting services out to those communities, we purchased these little tiny machines that can test for flu, RSV, COVID out to every single one of our villages so that testing could be done at point of care in those villages at that time, but then we have to fly medication out to them. And when the vaccines came out, we chartered planes so that we could go between each of those different, like we would hit like 5 communities at one time in one day so that we could get as many people vaccinated at any given time. So environmental impacts and use of like natural resources and stuff like that, I'd say in some ways went down, but also went up. And then the impact to our community members in terms of access to resources, we are still seeing the effects of that. We still have limited flights going in and out of our communities. That impacts people's ongoing access to all sorts of things, medical care. And then the cost of food has gone up dramatically in our villages. And then medical waste, if you look at the impact of medical waste, I mean, that's a huge problem in and of itself. But the amount of single-use, like syringes and everything that we had to do, gloves, all of those things that increased. How do we get that trash out of our communities with all of those gloves that we had to use, changing in between each patient, the masks, all of that sort of stuff. We actually, as an organization, because when the pandemic first hit, we didn't have a stock supply of PPE available, so we had to figure out a system on how we could process the PPE so that it could be reused between patients, and we had to come up with a system that, our N95s that we used them all day long and stuff like that. So I definitely think that there were huge environmental impacts from our perspective.
Yeah, I would say, so some things that came to mind for me, one of the impacts we've seen on our campus population is basic need insecurity and just a huge increase in that. So housing insecurity, food insecurity. So we have a food pantry that's a student-run organization on campus that has grown immensely in the past year and a half. We've seen thousands of pounds of food going out of there in a month compared with, I would hate to guess how much that has increased just exponentially. And so having to be creative and thinking outside the box and forming new partnerships with how we run that food pantry to make sure we're getting students what they need, getting creative with our housing contracts. What are other options for folks? We do not have very many options for students in our community who may have no income or low income. And so just having to really rethink through a lot of those environmental aspects that many folks in our community prior to COVID didn't think was a student issue. A lot of folks think college students are all rich and come from families with a lot of money, and we know that's not the case, and we're really seeing that now. And so one of the things we've been trying to do since COVID is we joined a community task force where we've really been trying to highlight that, because a lot of folks in our community like to think that our campus is its own separate thing and we're not really part of the community, but we know that's not the case. And so helping them to understand that our students really do have needs as well, and how do we partner with our communities to leverage those resources better and get people what they need. Medical waste was another huge thing that came to mind for me. We don't have a lot of the geographical challenges that you do in Alaska. But again, having to partner with our local health clinics and county hospitals and even state hospitals to get resources and also to handle waste from those resources. One other thing I wanted to touch on that was, I would say, a really neat thing that came out of COVID. Our diagnostic lab has the highest food animal caseload in the country and one of the top ones in the world at Iowa State. They run PCR tests on pigs mostly, but also other species, huge amounts at a time, and that was something they had been doing for a very, very long time. And so one thing they were able to do during COVID was shift to testing human samples using that equipment. And so they were able to get accredited to be a human laboratory. And so they actually, up until just a few months ago, were doing all of our testing for our Iowa State campus, but also for our local community. And even across the state, as there was surge capacity needed, they really served as just an enormous resource. That is something that was never there before. And because of that, while they have, they're no longer doing that right now because the need isn't there, and they're drowning in high-path avian influenza currently, but we have that resource there, right? So the next time that that's needed, we can set it up more quickly. And the same thing with our public health infrastructure. You know, we built these teams and we keep those relationships there. It's so important to do that so that the next time those are needed, we can stand them up more quickly. We can use those lessons we learned, keep the relationships so that we, because really at the end of the day, you just see this consistent need for resources, whether that be human resources, supplies, and then how do you deal with the waste that comes out of that? And we all have to partner together to get that done. So if you can leverage those things, it does help. But yeah, there's just a huge shift. And even, I would say another thing, the way that we deliver education at Iowa State, we had to rethink that. It doesn't look like it did before the pandemic. We still do most of our things in person, but we have a lot more flexibility. Students are offered classes that they can go back and watch online later to encourage students to stay home when they're sick. That was something our faculty weren't really willing to do prior to COVID because they felt like students would use it as a way to skip class. So the paradigm has shifted there a little bit, and that just takes some time, but we really have to be creative about the way we approach it.
Much. We have 5 more minutes left. Are there any other questions in the room? Yeah, Ina. Yeah.
Actually, I was just going to make a quick announcement about many of the themes that you talked about, things that also came out in interviews that we did in Lucia, people about the impacts of the pandemic and how cultural values and practices help people cope and get through. And there's a poster presented by Nicola and Cody that will be there that touches on those themes.
Hi everyone. My name is Jessica and I come from Canada and I work in and am from a couple of different Inuit communities in northern Canada, and we also have similar like histories of the 1918 food pandemic and also TB as well. And I think we saw really interesting and innovative and early responses that exceeded what was being done on the federal level. And I think I was wondering about your experiences and if you had any reflections on like a strength that you think occurred in your communities or institutions, and something that maybe was done that was innovative or different, and maybe other places could learn from as well. So thinking about some of the strengths that existed in the responses.
One of the things that was really instrumental for the smaller communities in Southeast Alaska was that the Tlingit people had agency over the response. And it was, and I can only speak from the perspective of, the research that I've been doing, and not as, a Tlingit person or someone who is from Southeast Alaska. But overall, what they've discussed is that, us having the ability to say what happens in our communities has been really instrumental. I touched a little bit on, in my talk before, about like trust in levels of government, right? And how trust in the federal government was really, really low. And what came up a lot was this idea that the federal government doesn't think about us when they make their recommendations. There was this feeling that, you know, if it was coming from, you know, Dr. Fauci or, you know, whoever, it was not for Alaska, right? This feeling of being very far away, and that, you know, they don't know what we're going through, and just the inability of the U.S. federal government to understand the needs of Indigenous people, period. I think, you know, the thing that really elevated their response was that they took control and they were able to do what they needed to do. So they had agency in closing their island communities. They were able to, you know, they made the decisions to take up those vaccines. And like I said before, they were willing to do that because it was really about, you know, what do I need to do to get back in a room with my elders again, right? So that we can, you know, get back to the way it was. So, for them, it was all about the agency that they were able to seize for the moment.
So I think one of the things that Tanana Chiefs Conference did that I'm really proud of is our distribution of vaccines. So because we got a vaccine distribution from the Indian Health Service, we got a larger amount faster than the general public. So we were really lucky that way. So we were able to vaccinate our population very quickly. And like I said, we chartered planes out to villages. And then what we did, because we had these vaccines and the general public was really like wanting to get vaccinated, but they had these restrictions on what tiers could get vaccinated at what time based on your risk level. And so we were able to open up our distribution of vaccines to the general public as well. And so we invited people into our health center, and we were able to share that with the community. And I think that was really, really wonderful. It was so wonderful to see community members come into our organization and be socializing, smiling, see how beautiful our center is, because I don't know if any of you have been to the Tribal Health Center here, but it's gorgeous inside and there's art everywhere. And so, you know, in a community where we have kind of historically felt a little separated, that was really welcoming. And then what we did as well, and other places in Alaska did this as well, is they were able to start sharing with the Canadians too that didn't have access across the border, because we got vaccines faster. Our lead pharmacist, he would get up at 3 in the morning and package all the vaccines in these special coolers to get them out to the villages. And he actually won the highest award for pharmacists in the nation. There's an article about him in the paper. It's called the Bowl of Hygeia Award. So I just think that's something I think that we're all really proud of that we were able to do, and it kind of highlights our sense of community, right? Our community wasn't just our Indigenous beneficiaries in the city. Our community was Fairbanks and all the other villages that we serve. So.
We're running low on time, so I'll go quickly. But similarly, so Iowa State, our campus has very large facilities on it, gymnasiums and things like that aren't available in other places in our community. So we did a similar thing where we were able to partner with the community to become the logistical center and vaccination site for our entire county. And so not only were we able to offer the vaccine to our faculty, staff, and students, but also to members of the community. And because we had those large facilities, it was able to be done in a really efficient way. The parking was available. The flow of traffic could be done in a way that prevented further infections. The community contributed staff. We contributed staff. It was just a really neat thing to see people really coming together. And, you know, it was kind of a time of joy because it was finally this good thing that was kind of a light on the horizon. And the other thing I wanted to mention, our Cyclone Cares campaign that I mentioned earlier, it really kind of took off and had this, you know, specific branding that was done. And we had digital things and paper things, and our community adopted that as well voluntarily. So our local hospitals and everything, you would see those same consistent messages and that same branding done all the way across our whole county. And it really kind of helped pull together not just our campus community and people that worked or went to school at Iowa State, but really our community as a whole is kind of this cyclone family, and it really kind of helped people to see each other as a family and a community rather than that individualistic approach. But and happy to say we've continued to carry that vaccination strategy on. So our student health center is actually the county's Mpox vaccination site, the only one, and we have been the entire time that outbreak has been going on as well. And so I think that will carry on far into the future, and it's just opened up a lot of partnerships that weren't there before.